On behalf of my co-authors, I would like to thank the conference organizers for the opportunity to present our work on hormonal contraception and cardiometabolic outcomes in women living with HIV. Women living with HIV are at an increased risk of cardiovascular disease compared to women without HIV, and certain forms of hormonal contraception are associated with an increased risk of cardiometabolic disease. As our patients are living longer due to improved antiretroviral therapy, it has become important to manage these comorbidities in our patients. In this study, we sought to examine whether and how hormonal contraception exposure was associated with incident cardiometabolic outcomes. Our study included HIV-1 infected cisgender females aged 18 to 45 years of age who were enrolled in care at the Vanderbilt Comprehensive Care Clinic from January 1, 1998 to December 31, 2018. Our clinic serves approximately 4,000 patients, of which 21% are female. Our clinic provides women's health services, including pap smears, prenatal, and obstetric care. Patients were excluded if they were of male sex, over the age of 45 at time of clinic entry, or if they had prevalent breast or ovarian cancer, history of bilateral tubal ligation, or hysterectomy at clinic entry. Women did not contribute data during pregnancy, but were able to contribute data before and after pregnancy. Patients were followed from their first non-pregnant clinic visit until they were lost to follow-up, death, or the end of the study period. Our primary exposure of interest was time-varying and cumulative use of hormonal contraception, defined as greater or equal to 28 days. This included oral contraceptive pills, injectables, or implants. Time-varying exposure reflected whether or not a woman was recorded as receiving hormonal contraception at a given point in time. Cumulative exposure reflected total duration of hormonal contraception exposure at a given point in time. Follow-up time for each woman was divided into periods of use and non-use of hormonal contraception. Our outcomes of interest were extracted from the electronic health record by our dedicated research staff. Composite endpoints were used due to low incidence of individual events. The composite outcome of cardiovascular disease included thrombosis as well as cardiovascular disease equivalents, as listed here. For the composite outcome of a metabolic disorder, this included diabetes mellitus, dyslipidemia, non-alcoholic fatty liver disease, as well as obesity. Marginal structural models were used because we had time-varying covariates that are both confounders and were suspected to be on the causal pathway. For example, the presence of metabolic disease could be both a confounder and on the causal pathway between hormonal contraception and cardiovascular disease. Weighting models were then used to create a pseudopopulation. The covariates were assigned weights based upon a patient's probability of being in one of the exposure groups, which allowed us to achieve balance in the population. Covariates in the weighting model included demographics and time-varying antiretroviral class, HIV-1 RNA, and CD4 count. Final logistic regression models were then used to evaluate the relationship between cardiometabolic disease and time-varying hormonal contraception use. Covariates in the final logistic regression model included time-varying hormonal contraception use, cumulative years on contraception, age at first non-pregnant visit, race, smoking status, CD4 count, as well as prevalent metabolic disorder event for cardiovascular disease or prevalent cardiovascular disease for a metabolic disorder event. Of the 729 women included in our study, 494 women did not use any hormonal contraception, and 235 used any hormonal contraception. The median age at clinic entry was 31. 40% of individuals were smokers in the non-user group compared to 46% of individuals in the user group. The median CD4 count at clinic entry was 407. There were more patients with hepatitis C infection in the non-user group compared to the user group. 47% in the non-user group and 49% in the user group had a prevalent metabolic condition at baseline. 15% in the non-user group and 14% in the user group had a prevalent cardiovascular condition at clinic entry. Among those who used hormonal contraception, the median time on hormonal contraception was 1.65 years. Of the 117 cardiovascular disease events that occurred, the most common incident event was hypertension. Of the 172 events of metabolic disease that occurred, the most common incident event was dyslipidemia, followed by obesity. Of the 729 women included, 111 women had a prevalent cardiovascular or thrombosis diagnosis at baseline and were excluded from the analyses. The cardiovascular disease analyses included 618 women, and there were 117 incident events. Current use of any hormonal contraception compared to no hormonal contraception use was associated with a twofold increase in the odds of cardiovascular disease. Among current users of oral contraception, there was a threefold increase in the odds of cardiovascular disease with an adjusted odds ratio of 3.35 compared to non-users of oral contraception. Current use of depot-medroxyprogesterone acetate, or DMPA, was not associated with an increase in the odds of cardiovascular disease compared to non-users of DMPA. When we look at cumulative use, any hormonal contraception was associated with a 15% increased odds of cardiovascular disease per cumulative year of hormonal contraception compared to no hormonal contraception use. Cumulative use of oral hormonal contraception was associated with a 29% increased odds of cardiovascular disease per cumulative year of hormonal contraception compared to non-users of oral contraception. Cumulative use of DMPA was not associated with an increase in odds of cardiovascular disease compared to non-users of DMPA. Increased risk of cardiovascular disease was associated with prevalent metabolic disease at baseline, non-white race, as well as smoking history. Of the 729 women included in the study, there were 350 women who had a prevalent metabolic disorder at baseline and were excluded from the analyses. The metabolic analyses included 379 women, and there were 172 incident events. Current use of any hormonal contraception was not associated with an increased odds of metabolic disease compared to non-users of contraception. Current use of oral contraception was not associated with an increased risk of metabolic disease compared to non-users of oral contraception. Current DMPA use was not associated with incident metabolic disorders compared to non-users of DMPA. Cumulative use of any hormonal contraception was not associated with an increased odds of metabolic disease compared to no hormonal contraception use. Cumulative oral contraception was associated with a 23% increased odds of metabolic disease per cumulative year of hormonal contraception, but this was not statistically significant with a p-value of 0.08. Interestingly, increased cumulative DMPA use appeared to be associated with decreased incident metabolic disorders. Increased risk of metabolic disease was associated with prevalent cardiovascular disease at baseline, as well as non-white race. There were several limitations to our study. This is a single-site study, and due to the observational nature of the data, there are likely unmeasured confounders. Additionally, the medication history was determined by what prescriptions were sent in the electronic health record. However, there was not a way to determine whether or not patients filled their medications and took them. This is especially true for the oral contraceptive medication history. Our comparator groups included women who were on other forms of contraception. We were unable to compare risk of cardiometabolic disease by specific forms of contraception. In summary, current and cumulative hormonal contraception use was associated with an increased risk of cardiovascular disease, particularly oral contraception. Cumulative oral contraception use was perhaps associated with an increased risk of developing metabolic disorders, but this was not definitive. Our results suggest that cumulative DMPA use was not associated with an increased risk of metabolic disease and may actually be associated with a decreased risk. These findings deserve further study. Given the high incidence of cardiometabolic disease in our patient population, it is important to take an individual's risk of cardiometabolic disease into consideration when selecting a contraceptive method. Thank you sincerely to my co-authors listed here and our funding sources, as well as our patients and providers at the Comprehensive Care Clinic. I would be happy to address any questions.